Hi, I'm Mark Ho-Asjoe, plastic surgeon. I'm really excited and honored today to have a conversation with Maria, who is the founder of Mummy MOT, to discuss about rectus diastasis. As a plastic surgeon, we do see a lot of abdominoplasty patients who has rectus diastasis, and I would very much like Maria's opinion on the pre-op treatment from a physiotherapy point of view and the post-op, and how we can help with patients. Hi, Maria.
Hi, yes, I'm Maria Elliott. I'm a pelvic health physio and founder of Mummy MOT. And, part of the Mummy MOT is checking the tummy gap and checking the abdomen. And we look at everything else. We look at posture, how mums are moving, but it's really the tummy and the pelvic floor that everybody wants checked. So that abdomen and tummy area on a Tuesday here, we're blessed now, we've got a busy clinic with mums coming in and out. So we check that, and ideally mums don't need an abdominoplasty, but there are a certain number of mums that do. And generally they're the mums, aren't they, that have done the rehab, they're 12, 18 months post-surgery or post-delivery, and they stop breastfeeding, and often we would send them to you then for a consult. And what we often look at as well before surgery is we often have to change sometimes the way mums move or breathe, so that once you've done your wonderful surgery, then we get an optimal result afterwards. So ideally we would see mums 4 to 6 times before they'd ever have surgery, and then they have a plan and a roadmap for what they need to do from a physiotherapy point of view once you've done surgery. And then every tummy gap is different, and then sometimes the rehab following surgery varies as well depending on the mum.
I mean, I'm very lucky to have you here, because the patient group that come and see you and come and see me is expecting slightly different thing. In my case, they sort of come in asking for abdominoplasty, but on examination I noticed the rectus divarication, while yours is about already improving the rectus divarications. I feel that a lot of my patients would benefit from seeing you before surgery. How do you feel about that part?
Yeah, definitely. And I think, the statistics would say that 1 in 3 mums will have more than a 3-finger gap at 12 weeks. And often that doesn't change unless we change something. So we have to think, why does that mum still have that separation? And is it her posture? Is it her breathing? Is it her connective tissue? So there's a lot that we can do. And it's also, isn't it, about checking, because of that divarication and the rectus diastasis, what functional problems are they getting? Are they having back pain? Are they having tummy pain? Are they constipated? Because there's the loss of that support fascially and with the muscles to their internal organs. So there's so much that we look at. It's not just measuring the tummy gap. We're looking at, as I said, function. And mums need to be really strong, don't they, in their centre, because now they've got, these children and kids that want to play football and that want to go and give them these, big bear hugs. And if they feel vulnerable in their centre there, abdominally, they're not going to move correctly, they're not going to breathe correctly. And that's where, yes, doing an abdominoplasty and surgery is kind of not the last option, but we do try everything else beforehand. But then once that decision is made to proceed with the surgery, I think it's really, really important, isn't it, that we're all talking and we've got a plan in place. And then you get the best results post-surgery. And then sometimes we find, isn't it, and you would know this, everybody heals differently, don't they? So sometimes we've got to do a bit more work on the scar. And we might have to do some manual therapy, we might have to use LPG, and then with some mums we don't at all of that heals really well, and they don't have it doesn't restrict their movements and function. And I think the other question we often get when mums come from a Mummy MOT, and from actually the Mummy MOT practitioners, is about the hernias. And is there a hernia there? What do we do? What surgery, what symptoms should we look out for from a practitioner point of view. So what do you think what symptoms or function do we need to check for the hernias?
I mean, that's a very interesting question on the basis that some people call the rectus divarications a ventral hernia, but ultimately it's a separation of your rectus muscles with the linear elbow in position, but just widened. Some ladies, because of the abdominal pressure during pregnancy, they develop a hernia around or near the belly button, which is either the umbilical hernia or the periumbilical hernia. They're usually small, they usually in general don't cause any problem. And in African-Caribbean group, a lot of them actually has a umbilical hernia before they have any form of rectus divarication. So that can be treated at the same time. I think surgery is about repairing the rectus divarication, possibly if there's a hernia, we can do it at the same time, along with removing the excess penises in the lower part of your abdomen. So giving them the good physical appearance, and also they do change their posture after we've done all that.
Yes, yeah.
Yeah.
And often you do have to remove, don't you? Especially if the skin has lost its integrity, and there's lots of stretch marks, isn't it? You have to take away some of the skin, and then everything is much tighter afterwards. But then sometimes that, doesn't it? It restricts how the mums can breathe and how they can move. So that's where we sometimes have to get back to basics. Like,
Can I ask you an interesting question? Because we have now tightened the abdomen by repairing the rectus divarications, some of our patients afterwards, sometimes they feel a bit bloated after dinner, and it's simply because everything is tighter. Also, the second part is that we know pregnancy can have some effect on the pelvic floor. So by tightening that, what would you advise our patients to do after surgery to help with the pelvic floor pressures and the bloatedness?
Yeah, that's a really good question, isn't it? And often isn't it surgically everything looks great, but then you end up with some new functional problems. So again, as we improve the tension here, then the pressure can go somewhere else. So you can get hemorrhoids, you can get symptoms of prolapse. So as you say, that's where we have to also keep an eye as pelvic health physios and check what's happening with the pelvic floor, and make sure that post-surgery that they really start with the pelvic floor, so they get that pelvic floor lifting, they get that connection with our deep TVA. And often, again, everybody's different. We might have to do some manual therapy. We saw that patient where, that transverse colon just seemed to be way up here post-surgery. So once we did some manual therapy and released the scar following surgery, she was able to breathe much better. So yeah, often that combination of manual therapy and also keeping an eye on what's happening with the pelvic floor. Sometimes we use our pelvic power chair, which I love, to kind of keep the pelvic floor nice and strong. And I think actually we don't do that routinely, but that's probably a good idea at 12 weeks post-abdominoplasty for everybody to have the pelvic floor checked. That would be an excellent idea. You always have great ideas, don't you?
I think this... at least from my point of view, is that I'm very fortunate to have you here at 4 Upper Wimble Street to be working together, bounce off ideas, and for a while we have been thinking about setting up some form of proper protocol so patients have the maximum amount of benefit, because some patients have abdominoplasty elsewhere and they don't get the physio with it, and sometimes, as you say, they come and see you, and we're lucky that I can just drop by your part of the office and have a look at the tummy and see what could benefit the patients. I think we're just having a very fortunate position here.
Yeah, exactly. And I think, as more and more mums are coming now for a Mummy MOT, the team of physios is growing as well. And we've got some great new MSK physios. So they're really good at looking at how the mums move. And then we've got some great pelvic health physios. So I think it's all that combination of us all working together for the mums. So, thank you for helping us on a Tuesday.
No, thank you.